This is Lecture 7A, Motor System and Basal Ganglia. The objectives of this lecture are to define the basal ganglia and describe its parts, describe the main connections and functions of the basal ganglia, and describe disorders associated with the basal ganglia. The basal ganglia consist of four primary subcortical nuclear masses. These include the caudate nucleus and putamen, which are part of the striatum, and the globus pallidus, interna and externa. These are illustrated on this coronal slice of the brain, as well as on this sagittal image to help orient you to these structures. The functions of the basal ganglia are many. One function is to regulate cortically initiated motor activity by modifying and refining it, not controlling it. Another function is to adjust associated automatic motor movements, participate in learned reflex control, and mediate memory, emotions, and cognition and language. I mentioned that a function of the basal ganglia is to refine motor movement. So a lesion of the basal ganglia does not produce paralysis. Instead, the impairment would be a loss of inhibitory control with resultant involuntary movements. And these would be manifested in movement disorders in which an individual displays dyskinesias or excess movements, dystonia, in which a muscle contraction is sustained, the most common form being writer's cramp, bradykinesia or slowness of movement, hypokinesia characterized by diminished movement, and akinesia, the absence of movement. The basal ganglia and cerebellum function together to refine motor movement. This schematic illustrates the feedback loops between the basal ganglia and motor cortex, as well as the cerebellum and motor cortex. You'll notice that in the schematic for both the basal ganglia and the cerebellum, information is relayed through the thalamus. So the basal ganglia and the cerebellum modify movement on a minute-to-minute basis. The motor cortex sends information to both, and both structures send information immediately back to the cortex via the thalamus. The output of the cerebellum is excitatory, whereas the output of the basal ganglia is inhibitory. So a balance between these two systems is important to achieve smooth, coordinated movement. And again, a disturbance in either system will result in movement disorders. In the next several slides, we'll talk about the circuitry of the basal ganglia and the four major loops. But you can see that the basal ganglia circuitry involves the cortex, the striatum, the globus pallidus external, and globus pallidus internal, as well as the thalamus and motor cortex. So there are four major neuronal loops or circuits. These have inhibitory or facilitatory effects The afferents are to the striatum from the motor cortex, and the efferents are to the thalamus by way of the globus pallidus. These motor loops are interconnected, and again, they are inhibitory or facilitatory. The cortical and brainstem afferents to the basal ganglia enter the striatum. The efferents of the basal ganglia leave the globus pallidus and project to the cortex via the thalamus. And each of these loops makes a contribution to the quality of movement. The first loop is the largest and most central loop. There are projections from the sensory motor cortex and prefrontal cortex to the neostriatum and globus pallidus, and then back to the motor cortex via the thalamus. The second loop is a bidirectional loop. So there are projections connecting the striatum to the substantia nigra. The third loop is also bidirectional with globus pallidus externa projections to the subthalamic nucleus, and then projections back to the globus pallidus interna. And the fourth loop is another bidirectional loop, which includes intralaminar and pontoverticular projections to the striatum. The striatum consists of the caudate nucleus and putamen. The striatum inhibits activity of the globus pallidus and substantia nigra. The afferents receive input from the cortex, substantia nigra, thalamus, and brainstem reticular formation. The efferents are from the putamen to the globus pallidus externa and globus pallidus interna. The globus pallidus consists of the globus pallidus externa or globus pallidus external and globus pallidus interna or globus pallidus internal. The afferents enter the globus pallidus from the striatum and subthalamic nuclei. The efferents are from the globus pallidus to the thalamus. In the subthalamus, the afferents are inhibitory from the globus pallidus externa. There are additional projections from the motor cortex and substantia nigra. The efferents are facilitatory to the globus pallidus interna. And this involves modulation of inhibitory striatal output to the motor cortex. A lesion of the globus pallidus can result in hemibalism, which results in large swinging type involuntary movements. The globus pallidus and substantia nigra are optimal sites for neurosurgical treatment of Parkinson's disease prior to the introduction of deep brain stimulation. Individuals with Parkinson's disease, which was refractory to medication, could undergo a surgery, a pallidotomy, which would attenuate the inhibitory output from the globus pallidus. When considering the substantia nigra, the afferent input is primarily from the striatum. There's additional input from the subthalamic nucleus, and pontoverticular formation. The efferents to the striatum via terminals containing dopamine. So there is a sending feedback to the motor cortex, and this feedback influences the motor cortex by facilitating, inhibiting, or disinhibiting components of the basal ganglia circuitry via transmitters. Involuntary movement is contralateral to basal ganglia lesions. With respect to clinical correlates, basal ganglia diseases result in a loss of precision and inhibitory control. One type of movement disorder includes dyskinesias, which may affect the limbs as well as speech musculature. Dyskinesias are treated with levodopa and also surgically through deep brain stimulation. So there may be a lesioning of the subthalamic nucleus to reduce the inhibitory output from the globus pallidus. Other types of movement disorders that one might see would include athetosis, which is characterized by slow, involuntary twisting of the axial and speech muscles, combined with hypertonia or excess tone. This can affect the buccofacial muscles, resulting in dysarthria and is secondary to a lesion in the globus pallidus. I mentioned hemibalism earlier, which is characterized by forceful, swinging, jerky, sudden movements of the arms and legs, and this is seen in association with a lesion in the subthalamic nucleus. Chorea is also a type of movement disorder in which there are brief, rhythmic, jerky, involuntary movements involving multiple muscles. Many people are familiar with Huntington's disease, in which there are these chorea-like movements. Huntington's disease is an adult onset disease and is an inherited and progressive condition. Less familiar is Sydenham chorea, which is a post-streptococcal infectious condition seen in children. A few more examples of movement disorders would include tremor, which is characterized by rhythmic movement, and this is seen in Parkinson's disease, a resting tremor. So when someone is sitting quietly, you may see tremor of their hands. Alternatively, there are action tremors. So the patient's extremities may be quiet at rest, but then when the patient is engaged in an activity, you may see tremor. This is associated with cerebellar disease. Other symptoms often associated with Parkinson's disease would include mask face or mask facies, infrequent blinking, slow movements, disequilibrium, stooped posture, dysarthria, and dysphagia. I mentioned dystonia earlier, saying that writer's cramp is the most common kind of dystonia in which there is contraction of a muscle resulting in fixation of a body part in a particular position. Myoclonus is isolated, repetitive movement, and sometimes as speech pathologists we'll see myoclonus of the soft palate or perhaps the larynx. And then there are tics, which are associated movement disorders in which there's throat clearing, sniffing, blinking, Gilles de la Tourette is another example of a tic disorder. One example of a basal ganglia disease is Parkinson's disease, which is characterized by the resting tremor. There's also cogwheel muscular rigidity. So as a patient's arm is brought into extension by a healthcare provider, there's not a smooth extension of the arm, but rather sort of a jerky or a ratcheting kind of movement as the arm is extended. In addition, there may be bradykinesia or slowness of movement, a loss of postural reflexes, a paucity of facial expression, and shuffling gait. And this is an example of, or an illustration of someone who may have Parkinson's disease. They talk about the forward tilt of the trunk and reduced arm swinging, rigidity and trembling of the extremities, and this short shuffling gait pattern. In addition to the choreiform movement seen in Huntington's chorea, there's also forgetfulness, personality changes, and clumsiness. I did not mention Wilson's disease earlier, but this would be another example of a basal ganglia disease. It is associated with a disorder of copper metabolism and is characterized by muscular rigidity, tremor, dysarthria, and possibly progressive dementia. PSP, or progressive supranuclear palsy, is a Parkinson's plus syndrome, which is often refractory to treatments such as levodopa. Sometimes patients also undergo botulinum toxin injections to address movements that are not under their voluntary control, such as involuntary eyelid closure. We know that in many of these basal ganglia diseases, there are aspects of higher mental function disorders because of the role that the basal ganglia plays in emotions, personality, and cognition, and also because we know there are projections from the basal ganglia to the prefrontal cortex. In addition, you may see frank psychiatric disorders in some basal ganglia diseases with depression, personality, and mood disorders.